a section there for webinars. So if you've got members of your team or people you think it would be useful to see this after and haven't been able to join us this morning, please let them know that this will be available. Please give my admin colleagues a bit of time to get it loaded, but it will be there. That's our plan. So we're absolutely delighted to have you joining us this morning. As I've kept saying, from housekeeping, if we can use mute for everybody while people are presenting, and if we can, we are planning to, Danielle's planning to speak for about 35 minutes-ish with a load of information, and then we're planning quite a long questions session afterwards. So if you could refrain from putting your hands up until that Q&A session, but we will try to spot all your questions and respond to them during in that section. We are very accessible. If we don't manage to get to you during that question, we never object to people dropping us a line and asking us questions. That's where we get most of our good ideas from, is from people like yourselves. So, you know, we're very open to suggestions and please, we regard the programme as a two-way conversation, so never hesitate to get in touch. And you're very welcome to put questions in the chat function. If you're, I don't know how many of you are familiar with the chat function, but if you look at the top, if you can see there's a little speech bubble. If you click on that, you'll see the chat function opens up, and then you'll be able to see the questions that people are posting. And if there's things you would like to respond to in that, by all means, please feel free to use for that. Now, the aim of this session is both an introduction. I mean, some of you will be aware of the work we've been doing for 3 years, but an introduction to the National Wound Care Strategy Programme, and particularly to education, which has been a key part of our work right from the beginning. The National Wound Care Strategy Programme came into being, it's nearly 3 years now. And when I came into post, we were asked to focus particularly on lower limb pressure ulcers and surgical wounds. So those are our focus. It doesn't mean we're not interested in other things. I'm interested in everything to do with wounds, but we need to focus on those areas because those are the areas where we know there are the most patients and the biggest problems. So, and if you try and do too much at once, you do nothing well. So we're trying to focus on that. I'm sure most of you on the call will be very familiar with the focus that's been on pressure ulcers, which is a very important area. But what is becoming apparent is that is a relatively small proportion of patients with wounds. I think it's the estimates, it's about 7% of patients with wounds, and about 40% of patients with wounds actually have a lower limb problem. So the lower limb problem is much, much bigger and has been really quite ignored until relatively recently. So a lot of our work is focusing particularly around that. Also, not only because it's the biggest problem, but it's actually the area where we reckon we can definitely make the most change, because that we know there is unwarranted variation, and particularly around the care of people with leg ulcers. And we also know that most people with leg ulcers have an issue around venous insufficiency. And there's really good evidence for if you give the right care to people with venous insufficiency and leg ulceration, you can really dramatically improve healing. So that is such a good news message for the NHS, because if we can do something about changing the service provision around lower limb, we can get people healed faster. And what we're saying is you do not need to cut your nurses, podiatrists and everybody else. What you need is to release those people, to give them time to care for all the other problems in the system, particularly after, following the COVID, and particularly the long COVID that we are now starting to see. So that's where the focus of our work is. We're also interested in surgical wounds. I was quite surprised when I came into post. I'm a community nurse by background, and I came regularly across patients with surgical wounds, but they weren't the biggie. But what I hadn't appreciated is that most people with a surgical wound get better, but the ones that don't, the problems can go on for a long time and consume a lot of resources. Although it's not such a big problem, it's still a big enough problem that we need to be looking at. And I can see those of you nodding in recognition of that. We are doing some work around that. We are moving slower on that one, but it's likely to focus mostly on surveillance of wound breakdown. And I say that deliberately. It's not just surgical site infection, it's wound breakdown. And speaking with my community nurse head on, I know patients at the moment, surveillance tends to end up when they leave hospital, or sometimes even the surgical team. And I know from my own experience as a community nurse, the problems often don't become apparent until they get home. And I'm going in every day, or was going in every day, for care of a dehisced surgical wound. So we think there's work that needs to be done there. But that gives you an overview of that. The final thing I want to mention before I hand the talking stick to Danielle is that we are well aware that there is a shocking absence of good quality data and information around wound care. So you'll hear a lot from us around data, what we're calling data, digital information, that we know we need to improve this, because until we improve our data, we cannot do meaningful quality improvement. And again, it's not a criticism of you guys on the ground. When I started in community nursing, in fact, weirdly, yesterday I went to have my hair cut, and yes, my hair has now got blue bits in it, in case you're wondering if it's the light, but I have now got blue bits in my hair because I felt the need. I found myself sitting next to my community practice tutor, who I hadn't seen, I reckon, for 25 years, which was just the most wonderful coincidence, because she was one of the most inspirational people in my nursing career. But I remember when I first went out as a district nurse, even as a community staff nurse, I was handed this gadget you had to put your data into. And I did it religiously because you had to, otherwise you got into trouble. And I'm sure a lot of you, most of you, will be doing the same. And I'm shocked to discover that all that data I was putting in has not been pulled through to where it needs to be pulled through. So we're dealing with that, but it is not easy. But just to let you know, when we come back to you and say we have got to do something with data, I know you've all been putting stuff into your records, but we are really now trying to engage with the people beyond you to say, well, if they're putting all this data in, how come we're not getting it for quality improvement? So just to let you know, we're doing work around that. I think that's the key stuff I wanted to tell you. I've probably, supply and distribution, yes. We are not responsible for procurement. I say that loudly, that the decisions about how you get your products comes from the Department of Health and Social Care, if you're looking at prescribing, and NHS supply chain. We are asked for advice, but that is not our responsibility. So please, we do feel your pain around some of those issues, but we can't actually do much more than yourselves in terms of trying to influence what goes on. So just to clarify that, but we are doing some work around that, and you'll see work coming out from us around that, particularly about trying to outline what are the there are different routes of supply, and what are the pros and cons of the different routes, because they'll vary depending on where you're working. And secondly, we're working on a national classification system for wound care, and I'm sure a lot of you will have actually had some involvement with that, and that is making steady progress. Right, enough from me. I haven't said deliberately anything about the education work of the programme, because I'm going to hand the microphone over to Danielle, who walked into one of my meetings very early on, made a big impression on me with her fabulous footwear, but also what she said and thought about education, and has been just such a friend to the programme and is leading our education work. Danielle is actually employed in Health Education England, but she has done so much for our programme, for which I'm really grateful, and I'm going to hand over to her to tell you all about our education work. Thank you.
Thank you very much. Disappointed I can't show you the today, but I will tell you about what we've done so far in education. Put yourself on mute. I
am going to put myself on mute, and I'm just going to say before I do, everybody else, there's a bit of feedback.
Oh, okay. Thank you, Una. All right, I'm going to share my screen now in order to start the presentation. So I am going to assume that you can all see that, because I cannot tell whether you can see that now. It's as if I've been blinkered and I can't see any of you. So as Una very kindly says, I'm Danielle. I've been part of the National Wound Care Strategy Programme since 2018. I have a background as a critical care and hepatology nurse, and I've been an educationalist in roles in education since, for over 15 years now. I am absolutely passionate about enabling education for as wider audience as possible within health and care. So although I'm a nurse by background, this is not just a nursing issue. This is about ensuring that the general workforce, who are patient facing, have the knowledge and skills they need in order to provide wound care. And I'm passionate particularly about doing that with innovative and digital technology. We know that across the clinical sort of environment, more and more technology is being used. And we've got a workforce, many of whom are unfamiliar with that technology. So if we can develop education using these digital and innovative technologies, we are both delivering education, but also skilling up the workforce to be able to use that technology in practice. Una's given a background of the National Wound Care Strategy Programme, and I'm certain that the majority of you will already be involved in it. But if we look at the aims to reduce unnecessary variation, to improve safety, to improve the patient or optimise the patient experience, to support prevention, assessment and treatment of people with wounds, and to optimise healing, education plays a role in enabling that to happen. The clinical work streams are working really hard and they've got lots of output now as the programme is getting going. And we needed to ensure that the education that we have is in line with the outputs from those clinical work streams. So therefore, and I repeat again, this is about educating the general health and care patient-facing workforce. So to improve the sort of baseline level of knowledge and skill regarding wound care. When we started the work in 2018, we had to ask a number of questions. Who provides wound care? And is this in line with who ideally should provide wound care? This is a really challenging question and certainly not one which is easily answered. There is a very mixed picture across settings and services, organisations, regions, and therefore the national picture. In some places, there is a really integrated provision of wound care across multi-professions. And in some, there is very siloed working, where only a part of the profession, usually nursing, is responsible for delivering wound care. And usually it is those people within specialist services. So a very mixed picture. So we knew, therefore, there was something we needed to do there with creating some consistency. We looked at the education that was already available, and again, bearing in mind who we're looking at here, so not specialist teams and services, but those people who work in a more general workforce, what education was already out there that was free to access. We did a large survey to our stakeholder forums, looking at how were they educated, how did they receive their education about wound care, and we found that the majority was delivered in-house by specialist teams and services. Some was delivered by suppliers and industry. And we asked, is there anything you would like? And overwhelmingly, across all professions and stakeholders that replied, they said they would like more online provision. Now, this might surprise some of you, and there is a mixed picture when it comes to online learning, but we do know that a more blended approach to education provides flexibility, so that people can learn when and where they are able to. That does not mean that it is the only way to learn, and it certainly still requires the consolidation in practice with good assessment and supervision of skills. So we looked at the free to access education, and then we did a tabletop exercise looking at the extent to which wound care or skin integrity was covered in pre-registration programmes. And again, we found a mixed picture, with some pre-registration programmes having quite a lot about wound care and others not having very much, or even in some cases not having it mentioned at all. So it is no surprise, therefore, that when you look at the clinical workforce out working currently, there are some differences of opinion about who has a role in wound care, and there are some people that still don't feel that they have a role within this space. We looked at the frameworks and standards that already existed to inform wound care and who they were for, and we found that really there was quite a number of documents out there, but they were often for parts of the profession or specialist services, or even for single wound types. So we knew we had to focus here. We've got variability in wound care provision, we've got variability in wound care skills and knowledge, we've got specialist services, and then we've got people who don't feel that wound care is part of their role. We needed to focus on setting the standards or setting the capabilities for the workforce as the first action that we took. And so this was our first aim, to set a consistent standard of wound care knowledge and skills across the workforce for England. Just that small task for a Monday morning. So we launched the Wound Care Core Capability Framework for England in June of this year, and it is the first wound care framework of its type. It was developed by a multi-professional audience, so we had a group of expert clinicians from across professions, allied health professions, including paramedics, physiotherapists. We had nurses, nursing associates, healthcare support workers. We had doctors, vascular surgeons, a number of professions, general practitioners. We also had representation from patients and also from organisations such as the Royal College of Nursing, the Queen's Nursing Institute, Skills for Health and Health Education England. And over a period of 6 months, used online, because this was during the pandemic, this group of experts have developed this capability framework, which can be found on the Skills for Health website. These slides will be available afterwards, and so therefore you'll be able to access this information. The framework is set in 5 domains, and if you look at those domains, you can see that the majority, the first 4, are wound care specific. And then it has been mapped across to other national frameworks. So therefore it includes the pillars of advanced practice, so clinical education, research and leadership, and it has been mapped to the national framework for advanced clinical practice and also the advanced lower limb capabilities as well. The 5 domains have 12 capabilities, and for each of these capabilities, they are written at 3 levels. So tier 1 is the foundation level knowledge and skills, up to tier 3, which are getting into the realms of more advanced practice capabilities or more advanced capabilities. And it's progressive. So in order to have tier 2 level knowledge and skills, you need to also have achieved everything in tier 1. Now, we have not been prescriptive on who is in what tier. This is, we've allowed flexibility because we know that when you look at specific roles, such as, let's give the example of a healthcare support worker, you may have a healthcare support worker working in a care home who has a big role to play with the kind of patients that they have and the persistent sort of pressure area prevention and other types of wounds, that they may need a higher level of knowledge and skill than, let's say, for example, a healthcare support worker who works in an outpatient setting. So therefore, it's impossible to map the tiers to specific roles. What you can do is look at an individual practitioner and say, for your specific role, what tier of knowledge and skills do you need? We have promoted this framework. As I said, it was launched in June. We've had a comms plan. It's going to be in a number of editorials. But this is just the start of the journey. There is a lot of work that now needs to happen. How can we best implement it? How can we encourage people to use it? We knew that in June, 13,000 people accessed the framework. But that just gives an indication of its after initial launch. Perhaps it gives an indication of how many people are interested, but it doesn't tell us how many people are using it. And that's where there's difficulties. There are challenges with looking at any educational output and saying, what is the impact that this education has? So we're working with the data, digital and information team to have a look and see what metrics can be collected or used, which will give us some indication of the impact of the framework as we go on through the number of months and years. Now, again, I said this is just the start of the journey. There's a culture change in some places that is required in order to accept that this is the knowledge and skills for everyone with a patient-facing role. As I said, there are some people who don't feel that they have a role in wound care. And so there's a lot of work that needs to be done at organisational level to accept and to use these core capabilities. As a programme, though, we wanted to ensure that it was as easy as possible or people were as supported as possible to achieve tier 1 level knowledge and skill. And that is the ambition, that everybody has a minimum of tier 1. So we've been producing a number of resources to support the skills and knowledge development at tier 1. So we have a suite of essentials modules. There's 5 currently available, and you can see the list there. And there is 1 still in development, which will be released this month. The first 3, skin care, wound assessment and lower limb ulceration were launched in January of this year. The following two have been from July this year. These have been developed by experts who are all part of the Education Advisory Group, who are the main drivers of deciding what subjects of education we then cover and develop education on. Without their expertise and their input, we couldn't do this. So if we look at who's using these resources, we can actually check, because they're hosted on the eLearning for Healthcare platform, which is free to access for anyone across health and care. And we've also got access for anybody who works in hospices as well. Although you do need to be working in an environment in health or care, we are trying to increase the accessibility as much as possible. So you can see from the enrolments that over 5,000 people have enrolled for these programs, to access these programs, and they've been launched over 10,000 times. The active users are the number of people who actually are using these programs regularly, so who opened it at least weekly. So that's a high number of active users who are really using these sessions to help their education. The Essentials of Skincare is the most accessed with over 4,000 launches. The highest proportion of people who are using it are registered nurses, healthcare support workers, particularly across social care, and there's a very high proportion of nursing and medical students using it as well. You will notice, however, that there are other professions are not using it to such an extent. And I have a question for you as to how we can improve that, or how we can increase that towards the end. The feedback from these sessions is excellent. So all of the sessions have an evaluation. They have a minimum of 4.5 out of 5 stars, and there are no negative comments recorded at all. And I think that is a testament to the quality of these resources and the fact that they have been co-developed with experts. When you think of online learning, you might have a terrible notion of mandatory training, trying to keep yourself awake while you click through the health and safety mandatory training module. We wanted to completely get away from that and have interactive, good visuals, really interesting content using different types of media. We have an illustrator that helps us to draw images such as this. And as we were going through the resources, we were finding it was actually very difficult to find really good pictures. So the illustrators are able to draw some of the pictures for us, but finding good digital wound images where there is sufficient consent to enable to use them in an education resource is quite difficult. And so as a result of that, we are now setting up a wound image library as part of the National Wound Care Strategy Programme. It's still in its early days, but all of the digital images and illustrations that we've used for these online learning programmes will be available in this catalogue in the future. They are interactive, so they require the users to be involved. You cannot pass and get a certificate unless you have been through every single part of each of these online learning programs, including all of the activities. You must have been participating in it in order to complete it formally. There are videos, there are films, there are podcasts, there are all sorts of different media and imagery, which helps people to keep engaged. And each of them takes approximately 30 minutes to complete. They're written at academic level 4, which again is helping to achieve tier 1 level knowledge and skill, but they are appropriate for across the workforce at any level of the workforce. Just because they're written a little bit more simply doesn't mean that they're not appropriate for a large audience. Now, we recognise that not everybody learns at their best using online learning, and online learning does have a lot of visual words on the screen. So we needed to provide and to develop resources which attracted different learning styles, or which were appropriate for different learning styles. And so we started a partnership with Desk Digital. Now, they are a company which produced this Signs of Life game. This was developed a few years ago to enhance the uptake of the sepsis bundle, the sepsis 6 bundle. It's been used a number of times. And the idea is that you had to manage a number of patients, all of whom were in a ward, and you had to treat them appropriately. Now, I've played this game a number of times, and it told you off a lot. Well, it certainly told me off a lot. And it was because it was written very in such a way that you had to not just choose all of the right options, but you had to do it in the right order. And then you had to tell exactly the right person that you'd done everything in exactly the right order in order for all of your patients to be still in the ward and not taken to critical care or worse by the end of your shift. We didn't want something we produced for wound care to be quite so telling off like. We wanted it to be much more educational and to build on the online learning programs that we'd already produced. And therefore they've started to develop a prototype for us. This has been funded by Health Education England to work with this company. So you can see, for example, that this is Betty. Betty's is it's an extension of Betty's story, which I'm sure you're familiar with. And Betty is now in sheltered accommodation and she has her lower limb wound won't heal. So you get some notes. You then get to look at previous treatment of that wound, and you get to then decide what you're going to do based on the current condition of the wound. As I said, this is designed for education. So this is taking you through the lower limb recommendations ultimately and helping you to decide on the right treatment for this particular wound. Now, there's going to be a number of different wound types across the 3 clinical work streams. So there will be a surgical wound, pressure ulcer, and a lower limb wound. And so the treatment choices, of course, are very different. And you'll have to do this managing these patients in a community setting. So it is hoped that this is another way of learning, but it also builds on the knowledge and skills that they've learned during the online learning, if that's what they've done first. You get alerts if you haven't done the right thing. So again, rather than telling people off at the end and saying your patient was moved to critical care because you didn't do the right thing, this is much more supportive in the way that it works. So that's one of the ways that we're trying to develop education, which uses different techniques. The second is by using virtual reality. You can see in this picture, the lady wears a headset, and through that headset, she's able to see a computer-generated environment, a 3D environment that can be interacted with. And in order to interact with that, you need special equipment, such as handsets, like controllers, or perhaps even gloves that use haptics. One of the things that I've been learning as I've been going through is that, and also from the research, and most recently from the Venus 5 study, that there are complexities with compression, that there is fear across some of the workforce about applying it, that there is non-concordance from people who are having compression, and it can be applied erroneously, incorrectly. And so I wanted to develop some education which helped people to practice without going and practicing on a person. So this is again in line with sort of COVID and restrictions, and perhaps you could be at home doing this, or you could be within a simulation suite. And using the VR headset and controllers, this storyboard you can see in front of you is just an example. This is just one of the examples of the companies that I'm talking to about developing a simulation scenario using virtual reality. So what would happen is that you would have a number of parameters at the start, which would say and confirm that you had a venous leg ulcer. You would be given some information about perhaps the level of exudate and the size of the wound, how long the wound had been present. And then you would have to do a number of things before choosing which compression was appropriate for that person. For example, you'd measure the circumference of the ankle, and you would get both visual confirmation that you were doing it right through the yellow band, but also you would be doing it using controllers, and as you measured using the controllers, it would give you feedback via vibrations that you were doing it correctly or incorrectly. The same with positioning the foot at the right angle and then applying compression bandaging. So again, the scenario would change depending on which compression product you were choosing. This is just an example, but it shows you what could be done with virtual reality, and this is what we will be working on in the future. There are first tranche implementation sites which I'm sure many of you will be aware of, and if not, you can find more information on the National Wound Care Strategy Programme website. The first tranche implementation sites are sites which are going to be implementing the lower limb recommendations, and they will be running services where those recommendations are followed exactly with regards to timings and processes. This is the lower limb recommendations in sort of visual form, and the FIMP sites will be running services based on these recommendations. Now, we have looked at the business case and the potential gains when services do this, and it's estimated that if sites and if these services are able to use these recommendations, that there are some estimated gains, both with regards to prevalence of lower limb ulceration, but also cost. And you can see from the graph there that the highest gains are estimated to be seen within venous leg ulcer management. And those gains are only increased over the years. There are 4 first tranche implementation sites currently chosen already, and they're going to be testing the assumptions of the business case. There will be 7 overall. There are another 3 being interviewed at the moment, so they will have 1 for each region as per NHS England regional footprints. Now, these first tranche implementation sites and the workforce that will be running these sort of lower limb services, there will be specialist input, but the majority of the workforce that will be doing and working in these clinics will not be from specialist services. And therefore there is an education requirement to be able to ensure that they have the requisite knowledge and skills to be able to do this. So we've been working with the clinical leads, both for the programme and also at the FIMP sites. FIMP is the shortened term for first tranche implementation sites. So we've been working to look at understanding the training needs of these sites and developing a curriculum which will be able to enable the knowledge and skills necessary. We've then done a gap analysis of free to access education, and we found that there are a number of areas that we need to now focus on to develop education in that regard. And you can see the list on the right-hand side of this slide. So do have a look and see. These are kind of our future focus of where we think we need to look. And of course, we need to prioritise. These are where we think at the moment there are gaps in education. For the FIMP sites, this education is not just all online. We will be looking at what would be best to be delivered face-to-face and how that can be done. So there's definitely a blended learning approach. And absolutely, supervision and assessment in practice is key. So not just education in isolation, but then how that is implemented. So that's a lot of work being done presently. And that's where our future focus for education will be looking at. But how can you help us with the next steps? There are several things that I've covered so far in this presentation, which we need your help on. Are there any other topics which you would welcome education resources on it? How can we encourage the use of the resources that we've already got and will produce in the future to be used by other staff groups? And how can you help with implementing the National Wound Care Core Capability Framework? So I'm going to finish there, and I'm going to welcome questions from the audience and to see if there've been any questions in the chat whilst I've been talking. Francis, have there been any questions in the chat?
Yes, I'm just having a quick look now. I've got one. Let's see. I've got one quite high up saying, do they monitor AHP enrolments?
Yes, so all of the online learning programs hosted on e-learning for healthcare, you are able to see how many people have accessed them, who those people are, and even geographically where they are as well. So we can have a look specifically at staff groups. So I gave you the highest proportion of staff groups that have accessed these, but we can see how many AHPs have accessed and even from where they're from.
We've also got, our industry able to log on and complete these modules without an active PIN number?
That's a very good question, and I'm not sure I know the answer.
I do, Danielle, because we asked this one before, and my understanding was if they've got a clinical input, they should be able to. But if anybody has problems with that, can I suggest they get back to Danielle and me, and we'll look into it further, if that's okay.
The platform has a really good help desk and support function, and therefore, if we can help to enable access, then we absolutely will do that.
I've tried to answer quite a few as we go along, Danielle. It's not that there aren't questions. I've tried very hard to do what I can.
Yeah. Oh, there's another one just coming from Kyla. What are the user groups wanting to encourage using the framework? Sorry, are you wanting to encourage using the framework?
Well, I think as you can see from the e-learning for healthcare use, that there is a tendency that nurses, that nursing students, that healthcare support workers, nursing associates, that they are the kind of the main users of things, because often they're the ones that are assumed to have the wound care related role. Now, I said that's not in isolation. There are many other professions and parts of the workforce that have a wound care role, but we still have these silos where some people really don't feel. So I'm not sure that I want to mention specific professions, but we do want all other AHPs and doctors, particularly, and general practitioners to be able to look at this, to be able to use the capability framework within general practice, within their general practice teams, and to say, are there any educational needs that we have here? Do we need development? Because it's looking at the team, looking at their capability, and then saying, where are the gaps and how can we fill those gaps?
And I'm not scared to mention professions. For example, we've just started some conversations with paramedics, because I regularly was getting approached by paramedics, would love to work with them. And, paramedics are no longer, even when they are working in ambulances, but quite often they're running services elsewhere. And there's an interest from those communities as well. So, it's not picking on paramedics, but it's just say there is an interest, and let's be collaborative. It seems the right way forward.
Absolutely. And we had a paramedic on the steering group developing the capabilities, which was excellent.
Oh, we've got one here. Could the AHP colleges, etc., promote the e-learning for health resources?
Absolutely. Yes, they certainly can. Every time we launch more online learning, we have a comms plan, and through that comms plan, we have a number of avenues that we promote these resources, including to AHPs and to Royal Colleges, to HCPC, to the regulators. A lot of avenues are covered. But I think what we need then is for people to actually take it up and use it. And there's, we're now looking at how we can help with that implementation from a programme perspective as well. But it is a lot about word of mouth, about people such as yourselves using it and promoting it and showing what gains can be had when it is used effectively.
I mean, one of the things I was thinking is, if I had a student with me, if I was still in clinical practice, I had a student with me, particularly if I was working in the community, and you know what it's like when you've got a student with you and they're hungry for knowledge and you are desperate for time, I would happily sit them down if they haven't already seen these resources and get them to work through them, because a lot of students aren't getting this in their pre-reg programme. We know they should, but they're not, and that's another thing we are going to be looking at. But in the meantime, if you've got a student with you, get them to log on and do this stuff, because there'll be far more. We can't replace that hands-on face-to-face stuff that you can do, but what we can do is help you out by making sure they get really good, high quality nuts and bolts for their knowledge, that they can then start to ask you sensible questions. So that's how I would use it if I was in clinical practice. And also members of my team, new members of my team, just, are we all singing from the same hymn sheet? Is our knowledge all up to date?
We've got one. Can the e-learning modules be linked to local ESR training records, so these can be recorded on staff records?
So absolutely. So everything on the e-learning for healthcare platform related to wound care is tied in with ESR, which means that once somebody has completed it, then you can see that on their ESR records.
Can I go back, Francis? There was a question higher up, which I just didn't get a chance to answer. Somebody was asking, I think when you were going through the different tiers, somebody was asking about standardization of job roles, because they're quite right. People's job roles and titles can cover so much. I think I'm not the expert on this, but I think it's reasonable to say it's unlikely we're going to go down the path of standardization of job roles, because it's not really our job, it's employers' job to do that. But I do feel your pain, and I appreciate it's a challenge. I don't know if you can add anything to that, Danielle.
No, I would just concur, really. I mean, that's a very complex problem, and I don't think that you will have seen perhaps on Twitter Alison Leary looking at trying to even get a protected title for nursing. You know, we're quite far away from looking at standardising job roles when we can't even standardise job titles. So I don't think that we will be focusing on that, unfortunately, during the programme.
Got one here. How can you help with the implementation of the framework we are launching? As said previously, a working group to assimilate the framework capabilities with our current competence and roles.
I can answer that one. Yeah. We've got our FIMP sites. We've got 4 already, which are Manchester in the northwest. We've got Hull in the northeast. We've got Kent Community down in the southeast, and we've got Wye Valley in the Midlands. And we are literally, I think interviews are ongoing as we speak for southwest London and east of England. Now, we can only fund one site. We're a very small programme. We make a hell of a lot of noise, but we are actually a very small programme. So we only have enough resource to actually fund one site in each region. However, we are aware that there are quite a lot of you out there who are absolutely dying to make change. And we are setting up a learning collaborative to where we will be able to recruit more widely, and we hope to be publicising this in the next week or so on our new website. So if you're looking for support, I'm afraid we don't have funding or anything like that, but what we do have is a really good network and information. So look at our website, keep an eye on it, we'll be tweeting it, but by all means have a chat with your organisation and get them to see if they're willing to apply to become our new learning collaborative, because we'd welcome you with open arms.
There's a question, Una, about guidance. Will there be guidance and ideas about manual handling and positioning patients who might be in pain to access tricky areas such as heels? Also, best way to see the wound clearly for assessment. From our perspective, there is some information both within the prevention of pressure ulceration session, but also digital wound imaging one as well, which talks about how to take pictures in areas that might not be so difficult to photograph.
I don't be doing something specific on that, but it's already considered within what we're doing. And somebody also, I noticed, somebody asked about, well, thank you for all the ideas coming in. As you'll appreciate, we have, I keep saying, we have limited resources. We're having to prioritise what comes next. We've got a, Danielle, what have we got up there so far? This is like me trying to remember what's there. I know we've got 5 out there already. We've got essentials of skin, essentials of wound healing, essentials of foot at risk, essentials of leg ulcers. What have I forgotten? Essentials of digital imaging.
Yeah.
And then we've got an essentials of pressure ulcers that's imminent. Is that right?
That's right.
And then we're just about to go back to the what's next to make our next list. I think it's highly likely we'll have something on essentials of wound product selection is likely to be there, because we know that's a big ask. And then we will look at your suggestions and see what ties in with where we think the priorities are likely to be. We know there's lots needed. So, and obviously we've also got to do all this work for the FIMP sites. Well, it's not just the FIMP sites, it'll be for all of you. It's around the implementation of the lower limb stuff.
I think it starts at the FIMP sites and then it will be rolled out and pushed out further. And something I forgot to mention, and this is related to a question from Jill in the chat about building relationships with patients for shared care and shared decision making, is that personalised care is absolutely accentuated in the core capability framework and in the education that we produce. There is always a how can you help the person to manage, perhaps self-manage. Are they appropriate to self-manage? And how do we have those conversations so that we have the best treatment plan for the individual? And I think this will be really key for the FIMP sites who will be having a lot of those difficult conversations. And although there are resources already out there on personalised care and how you enable shared decision making. We do think that we need something specific for wound care, having those conversations within a wound care environment, which will hopefully help with managing complex wounds and building those relationships, as you say, Jill.
And that also ties in with somebody's query I've spotted about non-compliance concordance from patients. And you're absolutely right. I mean, however we phrase that. Something I wanted to mention, though, is we've always tried to work with patients and carers right from the beginning, but it's quite difficult getting that engagement because often these people are quite frail themselves. And also there's a lack of confidence. But we are just in the process of contracting with a patient and public voice facilitation organisation to really strengthen that arm of our work. And we have in mind 3 areas that we particularly want to focus on in the first year, one of which will be around compression therapy, making sure the information that we get out to patients is much better than what we've got at the moment and presented in a way that is acceptable to them. So because we're here, we know, I mean, I wouldn't want my leg bound up with tight bandages if it was painful, all the rest of it. So there's a whole conversation that needs to happen there. We really want to help you have those conversations with your patients and your carers. So that's a piece of work we're definitely going to prioritise. Second one is around digital imaging. It's both helping patients take their own images safely and bit of good quality, but also understanding why clinicians may want to, and we hope they will want to take digital images of wounds and what that entails, and where they're going to be stored, all those other concerns patients are likely to have about that. And the third area we think we're going to start working on is a big area around pressure ulcers, because we're aware that the Legs Matter campaign has done great work for patients and carers around lower limb, but we don't think there's really any longer an equivalent resource for around pressure ulcers. So we want to start building something around that. There have been things, but they're a bit out of date now. They need addressing. So those are areas we are going to be looking at. And it's not strictly education, but it's information, and we're bound to overlap with Danielle in our work with that. So I hope that answers that. And somebody else, can I just pick up another one? Could the programme identify existing great resources that already exist? Yes and no. We have done, before we did any of this work, we looked at what was out there, and we really tried to not have to do, we don't like creating work for the sake of it. So we really tried hard that if there's good work that's already out there, we will be pulling that in and highlighting it. The problems we often had was it was not what we would call generic, it was product specific. Sometimes that's highly appropriate, but often it's not. Or you had to get through marketing to get to it. Some very good stuff out there, but you had to get through marketing to get to it. Or some of it was just not sufficiently up to date with the quality that was needed. And we also, I know the RCN validates existing education resources. We simply haven't got. We're not a big enough programme to be able to do that. So what we've done is look what's out there. If it's really good, we've brought it in, and if it meets our criteria. If it's not, then obviously we can't go around sticking our rubber stamping other stuff. We just haven't got the resource to do that. Is that fair?
Yes, and I think it's in line with, we've got clinical work streams producing outputs all the time, we need to be able to produce education which is in line with that. Yeah. And sometimes that will mean changing the education that we've produced already in light of those amends. And that's impossible if the IP is owned by somebody else. We needed to be able to own the property so that we can then amend it, change it, remove it even as required.
Yes. I was just looking at other things. It's lovely to see so many of you are finding our stuff useful, and we're really grateful to you for that. Please carry on using it, and also give us feedback. We're interested, we're open-minded. We do try to look. We will look at all your questions after this thing. So if we miss anything, I'm trying very hard. It's lovely having so many comments. But it's lovely to see this. I'll hand back to you, Frances, because you've got a more organised approach to picking up comments than me, as we know, which is why I rely on you so much.
Well, I've seen one here, though. There's how can the private hospitals improve and integrate with NHS for wound care?
Danielle, do you want to start, or shall I?
There's no reason the independent private voluntary should have access to our. So I think that if you don't currently log on to those online learning resources, please let me know. I will give my email in the chat box, and I will help you to get access to that. So certainly from an education perspective, I think we need to push this out as far and wide as possible. We're not protecting over the education we've produced. In fact, the opposite. We want as many people to use it across the country and even internationally as possible. From a programme perspective, Una, I don't know if you have sort of thoughts on working with the independent sector. And you're on mute. You're on mute, Una.
Come on.
That's it.
Yeah, I have to avoid double clicking because then I remute myself. It's just slow. When we advertised for our first tranche implementation sites, we asked people to come as a group of organisations. I don't think anybody came with their private providers, but we would have had no objection at all if they had. And in fact, moving forward, we would encourage that, you know, because we are looking at a with our first tranche implementation sites, we're looking at a health community, not just at a specific provider. So if independent providers are part of that, they're very welcome at our table. So if you're an independent provider, for example, working in Hull or Manchester, and you're interested in the lower limb work, go and get in touch, because I can't see why not. Certainly things like community interest companies, they sort of border the line between the two. Yes, please. We're not exclusive. We really don't want to be exclusive. The benefits ultimately need to be for the patients, and those patients access their care from all over the workplace. So it makes sense for us to join up our care.
Absolutely. I'm going to add a question from Jennifer Townsend about our future plans for education. So we're currently doing sort of education to support Tier 1, but absolutely the ambition is over the course of the programme, we will then produce resources to support Tier 2 and 3 level education as well. So we've started with the sort of the building blocks, the foundation building blocks, and on that there will be further resources at different academic levels as we go on, to be determined.
Yeah, one thing I would add to that, though, as far as Tier 3 is, we don't anticipate doing much evidence education there, because we would argue that most people working that level will probably ought to be accessing that level education from universities, HEIs, higher education institutions. And again, if you look on our website, we have a list of all the higher education institutions we're aware of that offer this level education. So if you're looking for something like that, have a look on our website. And equally, if you're offering that and you're not on our list, by all means, get in touch. We do our best to keep it updated, but we rely on you to let us know. Or if you're no longer offering it, let us know.
And I think for me, that's where the digital and immersive technologies can come in, because there is formal education that will be delivered elsewhere. And then what can we do as a programme to support that further? What innovative things can we produce which helps people to work at that more advanced level? So I think that there are some things, it won't be online learning, but what else can we do? And I think these are all conversations for our future focus, for our future work.
Frances, have you got anything else for us?
Thanks. A couple more here. Are the results of the education survey you undertook available?
This was done in 2018, so I don't think it was made available at the time. It sort of informed our thinking, and I don't think it would be appropriate now to put it out, as it's now 3 years. It was 3 years ago. I don't know, Una, if you agree.
No, I agree. But given that Sam's part of our advisory group, that's probably something we could share privately within that group in case there's anything there that would be useful. Aware, Sam, that you're also working at an international level, so we might have some useful. I think that would be an appropriate way to do that, if that's possible.
Yeah. Absolutely, no problem. So I didn't realise it was you that asked that question, Sam.
There's another one here. Do you know how much the headsets and controllers cost?
Yes, I do. So an Oculus headset is £200. Now that's quite a lot of money and quite a big outgoing, and therefore we've considered that in our approach. And Health Education England as an organisation has bought a large amount of these, which we will host in XR hubs. So virtual reality hubs, which will be sort of physical, where you can just hire, but for free, the headsets and the controllers that you need. So we will have large stores of those that you can then hire for your workforce. So we obviously recognise there's more complexity than that, because you do need to be able to use the technology. And for some people, that's, digital literacy is a problem across the whole health and care workforce, having some pockets of excellence and other areas where, we're not so savvy. And that's why I think using this from an educational perspective is really useful, because you can then learn to use that technology in a safe environment. But I do recognise that you do need some people with the skills to be able to troubleshoot, etc. When you're using those virtual headsets. So there's still some thinking to be done.
I'm going to hijack the last question, if that's all right, because I'm conscious we're getting towards the end of our time, and I assume that everybody has busy lives to get back to. But I just wanted to pick up the question from Karen Carr about mental health patients with wounds, self-harm and all that. You're absolutely right. And I'm delighted that I've got a subgroup going, because technically it's outside our remit, but we agree with you that it's really, really important. It's also not just the patients with self-harm, but it's the patients' leg ulceration or lower limb ulceration is very common, injecting drug users and that population as well. So we do recognise what you're saying. And our chair until recently was Baroness Watkins, who was a mental health nurse. So this was firmly on her agenda as well. We've got a new subgroup who are working on this. At the moment, you won't see it on our website, because our website is, hopefully launched today. It's sort of out there, but if you might be worth you leaving it a day or two. I tried to put the link in the chat, but I couldn't get it to load properly, and I think it's because they're meddling with it at the moment. But there will be a section on our website that we are turning over to this group to actually share knowledge and information about it. So please look out for that. And yes, we are working with them, and we are using their expertise within the group. I'm conscious, I very much doubt we have managed to get to the end of everybody's questions, and I can only apologise for that. After the webinar, Danielle and I will go through the questions, and if there's anything outstanding that we think we ought to do, we will do our best to pick up and get back to you with that. Is that reasonable, Danielle? I think we've covered an awful lot. And we won't get back to all of you, because some of them are just suggestions on things, and those suggestions we will just take note of. But if there's something that's pressing, we will endeavour to get back to you individually. Thank you so much for dialing in. It's lovely to know that there's such interest. We really welcome your thing. And please, if you're not already signed up with our stakeholder forums, please do that, because we do send stuff out, not frequently, but regularly. Plus you get our newsletters, and plus you're part of the family then, which always feels good. But we really welcome you being part and working with us, because the only way we're going to get change, and I know it's hard work, I know we don't have enough time, I know we don't have enough nurses, I know we don't have enough money, but unless we go the extra mile, we are never going to get the change. And I'm coming up to retirement now, so I would really like to be able to end my nursing career in the next few years feeling that we've really together made this difference. So onwards and upwards, hopefully. And thank you for your time today. And we'll say goodbye at that point. Danielle, I don't know if there's anything you want to add before we wave goodbye.
Just a huge thank you for your interest and for attending this webinar. Thank you very much.
Thank you, everybody. Bye-bye now.
Bye.
Thank you. Bye.